are always, we are afraid to have a patient at midnight. This is a call which we used to, we would want to have a patient of GI bleed when we were residents. We want to do endoscopies, more and more endoscopies. But as times have passed, now you feel that let the patient come in the morning. So it is a real challenge. So as sir has already said, GI bleeding is a huge topic and it was very difficult to cover it in 45 minutes, especially with 4 elite chairpersons and 4 panelists whom I have here. So I'll try to be very quick. My panel has already been introduced. Dr. Subodh Vashne, I think the senior most GI surgeon of the state. Dr. H.P. Yadav and Lalit Nihal, both very promising and prolific gastroenterologists of MP Chhattisgarh, and Pankaj Goyal, a very active interventional radiologist. So GI bleed is one of the commonest emergencies in practice. It can be upper GI, lower GI, obscure GI bleed, obscure overt, obscure occult. It can be variceal or non-variceal. When we talk of upper GI bleed, basically our intention is to differentiate best on clinical grounds whether this patient has got a variceal or non-variceal, because there is a clear divide and your patient will be managed differently in either case. It has also been classified as foregut, midgut or hindgut bleed, but I think basics remain basic and all of us must try and differentiate between melena and bleeding PR. That is the most basic thing, and there also we tend to commit mistakes. So it should be very clear that melena means black stool and bleeding PR is something like hematochezia or fresh blood pustules. It can be as torrential as this or it can be very subtle bleed. So whenever you have a patient of GI bleed, what are the issues to discuss? Role of endoscopy, surgery or interventional radiology, whether this patient needs ICU care or non-ICU care, whether endoscopy if required is urgent or emergent, whether patient has got comorbidities, whether there will be a mortality in this patient, and you should know what are the high-risk groups and how will you prevent. So GI bleed cases are always challenging. We have kept this panel discussion as a case-based discussion. I will be showing you some cases and will ask our panelist and chairperson and anyone in the crowd. I know there are very good gastroenterologists and surgeons and physicians, keen surgeons, physicians in the crowd. So case 1 is a 32-year-old male. He presented to us with history of syncope. He had perspiration, he was admitted somewhere in the periphery. He continued to have melena and hemoglobin was found to be 8.5. So this is a brief history. And this is what was I'll just take a minute, I have my laptop to the view.
PR, it varies significantly. Like you can detect 3 times more patients having melena on PR examination, so it's still very significant. And if you have fresh blood on rectal examination, or if you have a normal stool, it changes the diagnosis completely. So still I would say that even in this era, rectal examination carries a role. And Dr. Bhagwan, you want to comment on that? The likelihood ratio of if you have a fresh blood on rectal examination of having an upper GI bleed is very unlikely, especially if you have clots as well coming out.
So I think any patient who has got bleeding PR, so in upper GI bleed, it is a torrential bleed. And all these things are suggesting that they are abnormal. In that case, I would like to keep him in the hospital under observation, and we will try to do endoscopy within 12 to 24 hours.
Or we should do a lower GI, and if that is normal, then we go to upper GI.
NGA2 doesn't tell you that there has been upper GI bleed in the absence of history of hematolysis. So in that case, if there is bleeding here with repudiation of vitals, I think upper GI being a very simple procedure, we should always do upper GI endoscopy, and you get time to cleanse the colon also in between. So even if there is any suspicion of upper GI bleed, you have to do an upper GI endoscopy, and then you can get your colon cleansed if upper GI is normal.
The procedures, what is the time when you do an initial fluid resuscitation and then do a blood transfusion, or you would wait for the blood?
Admission, we send all the routine tests, and our aim is to keep hemoglobin around 8 to 9 gram, and the blood pressure, particularly systolic, should be around 90 to 100. So with this goal, we have to do fluid resuscitation fast, and in the meantime, we arrange for the blood, and within 12 hours, we would like to do an endoscopy.
We should have a more restrictive approach to blood transfusion. Our target hemoglobin should be 7 in the absence of comorbidities. So if the patient has active fresh blood coming in the nasogastric tube, yes, 2 units of PRBCs should be transfused along with plasma and platelets in ratio of, now they are saying the ratio of 1:1:1. And at the same time, if the patient has history of comorbidities like a coronary artery disease or a stroke, then our target hemoglobin would be in the range of 9 to 10. So in these patients, we will have a lower threshold for starting blood transfusions, because if you keep a threshold high, whether it is a variceal bleed or a non-variceal bleed, the mortality, length of hospital stay is much more if you transfuse more because of the transfusion associated lung injuries and fluid overloads. So a restrictive blood transfusion approach is now which is accepted. The other wants to make a point.
There is some exception to what he has said. Means the HP is 7 because there is hemo concentration. So in that group, obviously they need the blood. Okay, if it is 7, then you give a fluid, then it will become low. The patient
There may be argument about the target.
Low BP, in hypertension, we need blood.
I think we have already set in some discussions. So this was a 32-year-old male who came with history of syncope, and melena was there, hemoglobin was low, endoscopy was like this. I would like to show you a brief clipping. So this case I have taken because it is one of the commonest cases which we see when patients come with GI bleed. Okay, so that was the lesion. So maybe I can start with Dr. Lalit only. So Lalit, this patient has come with severe anemia and with a history of bleed a day before admission. And what do you say, what ulcer is this?
So according to, I can see a visible vessel there actually. So it would be 2A. And as we know in forest classification, class 1A and B would have a risk of rebleed to the tune of 50%. And 2B would have a risk of bleeding in about 30 to 40%. And once we go down below, rather easier to remember would be 40, 20, 10, 5. So every time you keep reducing the risk by half. And class 1A would be 50%.
So Hari, do you agree that this is a visible vessel?
Yes, it's clearly visible. It's a visible vessel.
So in fact on initial examination we did not feel that there was a visible vessel. There was an adherent clot. So if you look at the forest classification, what happens is adherent clot rebleeding rate you will assess only after removing the clot. In fact, not even adherent clot, we felt that there was a hematocytic spot, very tiny. But once we did some irrigation, then it became obvious. So I think the message is that you should always try and get to the root of it. Try and if there is a clot, try to dislodge it so that you can see better. Then what would you do? Now patient has come with severe anemia, severe bleed, and hemoglobin is 8.5.
So you have already removed the clot with irrigation, and after removing the clot, we have now the recommendation is that we should use two modalities of treatment. Don't use a single epinephrine injections. So you use an epinephrine injection for the tamponade effect and for the vasoconstriction. That is 1:10,000 of adrenaline diluted, and in the aliquots of 0.5 to 2 ml. Total volume should be in the range of 15 to 20 ml to get a good tamponade. And once you have achieved that, then the second form of therapy can be a thermocoagulation, it can be a heater probe or a gold probe, or you can use a clip, a mechanical device.
Right, so the message is that normally we would use two modalities together, one injection, one may be a clip. So in this patient, as when we were even discussing with the family, we called them inside and he started having a bleed. So we actually decided to go in with a OTSC. We wanted to be very sure that this will not bleed again. So what we did was we placed an OTSC.
Basically big clips, over the scope clips, and in a situation like this, because we can see some deformity around the ulcer and some fibrosis, I think if the patient can afford this modality, that gives very high rate of success and the risk of rebleed is very, very low. So which OTSC did you use, Sanjay? Scope.
Sir, with this injection therapy, like in this patient, there was no active bleeding. So I don't think there's a need for doing that. Likely you can go for either thermal coagulation or maybe for clipping. Obviously, it was not forcing simple hemoglobin because we're looking fibros.
Usually we have found that if you try and apply a simple hemoclips, one, it's technically not easy, and secondly, chances of bleed are higher. Sometimes start bleeding on the table. So I just would, before we proceed, I would like to tell that once these patients come to us, of course we have discussed hemostasis, but more important than hemostasis is that you have to stabilize these patients first. You have to assess the risk, and for risk we have what is known as Rocall scoring, and in which you have three clinical markers and 2 endoscopic markers. So you grade these patients according to the score, and if the score prior to endoscopy and score following endoscopy is calculated, so score following endoscopy is more than 11, then this total is 11, and risk of death is less than 5, the score is less than 3. So obviously the patients who have active bleeding, the score is higher and you have to grade them accordingly and treat with one of the surest method of hemostasis. I think we'll proceed to second case.
Other than OVESCO, you can use a simple hemostatic clip.
We could have used simple hemoclips, but as I said, once there is a little bit fibrotic base, it is difficult and sometimes it starts bleeding again. So this is the second case. I think during this mishap of this, I have lost the history of also some patients. So only numbers, but history is not there. So this was an old man who came with a bout of retching, and following which he developed hematemesis. Again, the hemoglobin was in the range of 8 to 9, and this is the video. This TV is not working.
See, this is esophagus, looking like a tear in the esophagus. Right? And there's some
it was
ongoing bleed also.
Yeah.
And you can tear is up to the mucosa.
So
You can see
normally
the
what we
muscle
see
layer.
is
So most likely it's a large malarious tear in the esophagus side.
in fact this malarious tear looked so deep that we were even suspecting that it could be something like a Bohr-Haave syndrome.
But you can see the clear cut muscle layer was here.
So again in this patient, since it was a very deep tear and patient had anemia, so what would you do?
See, if there's ongoing active bleeding, then you have to do definitely some treatment, and the best would be putting the clips. That by doing that you can close the defect also, and at the same time you can take the bleeding also. But first of before doing that, you should exclude the any leak by doing the X-ray chest or PVC.
I think the way Sanjay smiled on this case, I hope you have not used Ovesco again in this patient. Yeah, so I would make out
Because
that
on table we felt that it could be a deeper tear and we did not want to take a risk. We applied an Ovesco in this patient also. And the result was obviously good because on endoscopy currently the surest method to seal a patient who has got an active bleeding or who has got even an iatrogenic small perforation, the best way we have is to apply an over the scope clip, and that is like a surgical suture and it nearly seals the entire area. So again in this
I
patient
think the
we-
message should not go. Most of the malarious tears are low risk and
No,
don't
I
require.
want to show you
Yeah.
this, that this patient, even after applying an Ovesco, there was an area which was still bleeding. So we actually applied a standard hemoclip.
So up to what size of the tear you can apply the Ovesco?
So it's not about the size. If you're not able to control the bleed with injection therapy, then
The diameter of the Ovesco if tear is more than 2 centimeter.
we cannot use that.
then it-
Yes.
So I think it was about 15 in this case. Finally they got a cable and I'm probably using my own laptop. I think we have already exhausted a lot of time, so I'll cut down few cases.
Dr. Yadav, would you consider, if the tear was very big, would you consider using a removable stent for temporary closure? If it was a Bohr-Haave.
Yeah, it is perforation, it is ward up, then obviously the treatment becomes entirely different. In that case, maybe you have seen that perforation, putting a covered stent is one of the options. And putting a covered stent in normal human with the chance of finding. For that, we have some modified Ovesco kind of devices that you clip the upper end of the mucosa, the upper end of the stent, the esophageal wall. Just putting a simple clip doesn't work in most of the cases because the clips, simple clips are there. They just hold the mucosa on. Applying the Ovesco.
So what Dr. Yadav is saying that we could use covered stent in such patients, but the problem is that it tends to slip out. So we place a clip at the upper end of the stent to hold it there, but that also doesn't work because very soon it falls off. So there are special devices nowadays which are known as stent kits, so you can actually use that. Since we are talking about Bohr-Haave also, I would like to ask Dr. Varshney that what is his experience? You all know that Bohr-Haave is a full thickness tear in the esophagus and the prognosis is extremely poor. So Dr. Varshney, what is your experience about managing Bohr-Haave syndrome patients?
See, we try to do it with minimal intervention, and that would be like a covered stent with a chest tube, basically. That's the best option, and because if the patient is diagnosed within 24 hours, then this works. If it is old, then you start getting the wall gets very. You can't put a stitch in those walls if you operate, and if you don't put a stent, we have found that the hole gets so big that it doesn't stop the leak. So these patients are really difficult.
And patients are sick, so you cannot even do local esophageal
So
cavity.
unless you do a controlled, make a controlled fistula in these patients by putting a wide bore chest tube, so that whatever is coming out of the chest wall. Only then these patients.
I agree. Over the years, I think we have managed about 5-6 patients with Borhaus syndrome, and we could actually salvage 2 patients by this technique only, putting a stent, putting chest tube. But still their morbidity and stay is very long. And you will be lucky if your Borhaus patient survives. In fact, we used to say that it is a death sentence. So very quickly, I think this was the second case. This also we had applied Wesco, I think we have discussed, I will comment this. So this is the third case, 65-year-old male, had one large blood vomiting 12 hours before coming to us, resuscitated at periphery, and he had tachycardia, hemoglobin was 9, and this was the endoscopy. I can ask one of the chairpersons also. Shailen, do you see anything?
There is oozing of the blood at the, just below the G junction.
Just below the G junction, you can see a bleeder. Yeah, that's right. So this patient came with, we presume that his hemoglobin must have been, say, around normal person, 13, 14, and when he came, his hemoglobin was 9. He had a history of hematemesis. And this is what we found. There was nothing else on the
lesion, like there may be some delaphi lesion also.
Yes. So this was actually a Dulaphoid lesion at just below the G junction on lesser curvature side. Dulaphoid lesion, you all know, is basically a caliber persistent vessel which starts bleeding. On endoscopy, you will not find any ulceration or growth or polyp or anything. You will just find blood oozing from a particular place. So that was the finding. They are usually challenging to diagnose because they are not seen if they are not bleeding. There is no lesion. So we could see that there was a lesion here. So what would you do, Lalit? How will you manage? What are the options?
So again, in Dulaphoid, as we know, that sometimes they are missed and they can lead to massive bleeding, and there have been reported deaths as well. So it should not be, the importance of this should not be underestimated, and we must use endotherapy. And I would say again, Ovesco is one of the best options in these patients. And if
So
Ovesco is not available, banding or clipping with resolution clip is also an acceptable alternative.
Yeah, that's right. So that's what we did in this patient. We did not use Ovesco here. You will see. So we chose to use a simple device, banding.
Or a smaller lesion such a clip.
You can appreciate here that it is actively oozing when we try to apply band, and the entire lesion, entire part of the mucosa was sucked in the band, and patient did not have a rebleed. So it went off well. Yes, Shailen, you were saying something.
Comparison to band, clip is far better than that.
See, applying a clip just below the G junction on lesser curvature side is a bit challenging because you don't get enough space. If you go back, you go back into the esophagus. If you go down, you don't see anything. Ovesco is easier, but see, I think I can recall at least 3 patients of Borhaus which we have managed, and we have managed all of them with band only. Luckily, all of them are.
There is a supporting data on this, and they have compared band ligation versus use of hemoclips, and they found band ligation to be more effective than.
You can actually suck the entire lesion in, and that is a sure shot success.
No, I don't think.
So this is now we move to a different area. This was a 72-year-old male, choledocholithiasis with cholangitis. ERCP was done for removal of stone, but had massive spurt during papillotomy. Usual injection therapy with epinephrine and coagulation was tried, but patient continued to bleed. So what are the options? I think I can ask Dr. Bhagwan Singh Thakur.
So initially, if a patient is not responding, we keep the balloon inflated for some time and keep it for around 20 minutes. And if it doesn't stop, then I think the next option would be interventional radiologist. who should come into the picture.
Nothing in between.
Stand, yes, I think we can put a fully covered stands in this.
And 20 minutes, would you wait for hold the scope for 20 minutes with ballooning?
At least 20 minutes,
I think that's fairly long time.
long time.
Yeah, we usually for any tamponade therapy we would wait for 2 to 3 or 5 minutes. I think if it doesn't subside. This was just to show that it's red. So, what are the risk factors when you are embarking on an ERCP? What factors do you look for, Dr. Hari, during a ERCP? Which patients can bleed?
The risk factors patient on anticoagulant voluntary therapy and patients with cirrhosis and some data patient with diabetic lung or the use of very high tension while cutting on the tissue. Is there no sufficient time for coagulation in the cheaper cut and beginners and cut going in the wrong direction, very big cut or using the pretty cut.
Yes,
These are the risk factors.
So, any precaution do you take if you are suspecting that this patient may bleed during EPT? Anything you could
Yeah, the
do
one
in
thing
advance?
is for any procedure you should be ready to deal any complication. First is to look for the risk factor. Just
Can
like
you use
diabetes.
both mixed coagulation and cutting
No,
therapy?
usually we use that endocut for all. This is no recommendation, but we all are using endocut.
Can you use epinephrine as a prophylaxis?
No, this is not recommended. But being prepared for such kind of thing, everyone who is cutting or doing the endoscopy should have the covered stent in their endoscopy because this
So
may
all in
happen
all,
at
we
any
would
time.
try to
Don't-
manage. If you have a post-epilotomy bleed, which is not uncommon, they say that mostly the best treatment is that you wait. Most bleeds will subside if you wait for a while. If they don't subside, you will do injection therapy, you can do some coagulation, and if it continues to, you can do tamponade with a balloon, but if it continues to bleed, you have an option of putting a fully covered metallic stent. That is what we did in this patient. Just because.
You can put multiple plastic cells. In the CBD is the multiple cells. In one patient we put 10 plastic cells.
So how is that help? That will create some tamponade.
That's what the art is. Putting multiple plastic cells. You don't have a covered stent. You can try.
So you will put 10 stents.
Yeah, CBD is quite dilated CBD.
Okay.
So fill the CBD with multiple stents. It's possible.
Because did you complete the papillotomy or
Yeah.
so
If the vessel is cut, partially cut, so there will not be any contraction of the muscle. Cut the vessel completely, and sometimes the bleed stops. And if the bleed doesn't stop, initially we do the coagulation, and then we inject, and that doesn't cause balloon dilatation. And last resort is the multiple plastic.
That's right. This is one important part that if you are if you encounter a bleed while doing a papillotomy, please complete it because half papillotomy may lead to more bleed if the half vessel is
Even if
cut.
the vessel is partially cut,
Then you can
the bleed
extend
will
a bit. Yes.
Doctor, because this putting the stent in CBD, metal stent or plastic stent, that is required in extreme cases. Where your other treatment options are not working.
Right.
Like you have done the injection, you have extended the cut, you tried the coagulation with your distributome. Then we think for putting the stents. See, for putting covered stent, you are already in the CBD, you are already have the access, and over the same wire you put the stent. But for putting the multiple stent, you can put the one stent, then you go for the second, and a massive bleed, you may not see anything for putting the second stent in the second coagulation. So putting plastic should be the, fully covered stent should be the one. If it is not available, one can try. Yes,
That is all.
but it is difficult when there is a massive bleed in that room.
I think message is clear that this is a salvage method, but if at all you do not have a metal stent, you can try multiple plastic stents.
you use a hemoclip if it is at the edge?
normally what happens, if there is a torrential bleed, actually you don't see anything. The best way you think to bail yourself out is that your wire is in and you take your metal stent over that. And I think that is every endoscopy unit must have a covered stent.
With the siding endoscope, it's difficult to apply the hemoglobin.
Hemoglobins
You
are
will not
very
be able to
difficult.
read the hemoglobin.
So even lot of devices don't. In this patient, even after fully covered metal stent, it was bleeding from the edge, so we had to inject at that place and finally it subsided.
I think
And
it's the,
we in fact put a balloon through the stent to keep it there inflated for some time.
I think here we should take an opinion of our intervention radiologist. When would you like to come in?
Actually, we had managed one case where there was a pathology and it was continuously bleeding. In that case, what we had done is we had embolized the inferior pancreatic artery. It comes as a branch of the superior mesenteric artery. It was done around midnight. It was bleeding heavily. But I think after embolization, patient didn't bleed.
Yeah,
So it was fine.
Dr. Vashne, have you ever had a chance to operate on a patient with post-papilotomy bleed?
Yeah. We do syndroplasty in this case. That is, we put the stitches on the edge.
So it usually works. Long back I remember Dr. Loya did one of my case in my initial days of practice. Patient had papilotomy bleed and you did.
That time we did not have enough option.
Yes, we did not have so many endoscopy.
Combination of both perfusion and bleed.
That was about 20 years back. So I think I'll skip few cases because this one I can say. Okay, this is an interventional radiology case. So I'll just briefly say, I'll ask Pankaj. This was actually an elderly male CAGB post PTPD and stenting, otherwise recovering well but presented with lower GI bleed. So when he had a melena, we initially did an upper scopy to rule out whether he had any bleed in the duodenal area, but was not bleeding from there. And did a colonoscopy and found bleed. There was active bleeding somewhere in the right colon. So that is what we could infer at the best. And then interventional radiologist managed. Pankaj, can you tell about it?
This is the CT scan which was done during the while the patient was bleeding. In this scan, we cannot demonstrate actual bleeding, but we can only see that there is some high density contents in the cecal area. So, as sir had done low GI scopy, we had an idea that there is a bleeding somewhere in the distal ileum. So, we directly went in and I just hooked one of the branches of the SMM, and we can. This is basically DSA. In this DSA, you can see there is a active bleed which is coming from one of the small branch of the iliac vessel. It was a very small branch. It was actively bleeding. We just went in and we just embolized PA particles and gel form. But that patient was stable. Hemoglobin was stable.
So it was bleeding here.
It was a very small branch. We took up this patient when the patient was quite sick. At that time, we were suspecting that patient must be actively bleeding right now. Instead of going for CT scan, we directly took the patient for DSA. That is how we could catch such active bleeding cases. Like generally, we may not find active bleeding most of the time.
This is post-embolization, I think. There is no.
Yeah, this is post-embolization.
This was also managed well. The bleeding stopped. 38-year male, chronic alcoholic, vein abdomen.
I have a question, sir.
Yes.
So, did you retrospectively gone through reviewing your CT angio? Because again, nowadays CT angio, again we consider it is very sensitive. Antegrade so have you gone retrospectively looking after your CT images again, and had there any suggestion of picking up that okay, there was some abnormality, but yeah, we couldn't consider it just like
I stopped bleeding, in fact. Yes, I remember that. Again, the patient was stable. We didn't do anything after CT angio. We just waited. Let's see that the patient might stabilize. Then again, next morning, the patient had sudden fall in the hemoglobin. His hemodynamics were unstable. So at that time, we took up the patient directly for DSA rather than going for CT angio.
So possibly when he
So that's
That was the time of active bleeding.
Yeah,
so that's the perfect scenario in the GI bleeds. So GI bleeds are very recurrent. So possibly if you would have taken for DSA at that time, DSA would have been negative. And in the morning, if you had done CT angio, then CT angio would have been positive.
So instead of going for CT angio, we had an idea.
Absolutely.
Yeah, that is a common problem because till the time you arrange a CT angio or an angiography, bleeding stops. We have another patient last week, similar patient. So this alcoholic patient on endoscopy, this is what we found. Dr. Lalit, what do you see? It is very small, very short clip actually. Hemoglobin was 7.5, alcoholic.
So this was a side view endoscopy or an upper endoscopy? It looks like papilla, blood is coming out from the papilla. Hemosuccus pancreaticus is the most likely possibility.
So this is
in an
actually
alcoholic.
minor papilla, and we found, luckily we found bleeding from, because on upper endoscopy we did not find any bleed. So we thought, because patient was an alcoholic, we thought we might as well do a side viewing also. And luckily, while the time we were doing side viewing endoscopy, we saw this spurt of blood from minor papilla.
Then you went ahead and did a CT angio for him.
Yeah. So what would you do now? CT angio, correct?
You'll go ahead with the CT angio.
So CT angio was done.
If the patient is hemodynamically unstable, we'll directly go for DSA.
So I think we did both. First we did CT angio. Okay.
This is basically the reconstructed image of CT angio. In this we can see basically this is a celiac trunk and this is the gastroduodenal artery. If you see here, you can see a small nipple in the gastroduodenal artery. This is not a normal feature, and you can see this is the last pseudocyst here. So what we from this CT angio, what we suspected that this must be a pseudoaneurysm which has a blend into the pseudoaneurysm, and somehow this pseudoaneurysm is connected to the minor papilla. That is how this patient was having bleeding from the minor papilla. Then we took this patient up for DSA, and while putting this is basically a catheter, this is a microcatheter, we can see exactly the same picture as we have seen in the CT scan. We were not able to put our wire across the basically there was a rent in the GDA. GDA has actually given away, and we were not able to put our catheter across it to the lower side, other side. So what we did is we took the catheter into the pseudoaneurysm. We embolized the pseudoaneurysm with gel foam and antibiotic, and we came out and we embolized this artery with a coil. This is how we did it, basically. This is how we have placed injected gel foam into the cavity itself with antibiotic. Then we placed coils. This is the rent in the artery. Luckily, one of our coil migrated distally. So basically, we had trapped the aneurysm. This is some pseudoaneurysm, some coils distally and some proximally. So ultimately, we have embolized the pseudocyst as well as the vessel bleeding into it. The patient is doing quite fine now. This is a post procedure.
So I think that was managed well with the interventional radiology. For the lack of time, I think I'll skip this case. No, I cannot now. This is the only case I am going to ask Dr. Vashne. So this patient had upper GI bleed, 59-year-old male. He had progressive weakness and pallor. Stool was positive for occult blood. Hemoglobin was 8. And this was the upper GI endoscopy. So when we did this upper GI scopy, we were not finding any active bleed, nor there was blood in the lumen. But this was a huge compression in the stomach with possibly a kind of central depression, or you may call it a fistulous opening. There was some ulceration over the edge of the. So this was basically a large submucosal tumor in the stomach. So it was surgical opinion was asked. So what would you do?
Normally, we see if it is on the greater curvature or the anterior or posterior wall, then we can easily do a hybrid surgery, where you do an endoscopy. From the endoscopy, you can show the light, and then through a laparoscope, you do a sleeve. The endoscopy.
So what do you think is the pathology could be?
It could be a GIST.
So actually, I am not having the CT. I couldn't load it. So CT suggested a possibility of submucosal tumor, possibly a GIST. And the patient was taken up for formal laparoscopy and dissection. We didn't go for a hybrid surgery. So would that be an advantage?
Yeah, see, you don't have a big scar. and you are more accurate, you are able to see more of the stomach, because with the endoscopy you exactly know the.
If the tumor is large, sometimes you have to do a total gastrectomy also.
Yes, if it's a large tumor.
So I think our surgeons did a wedge resection and removal of
So
it.
the wedge resection is like a sleep.
Yeah.
Which you do with the endoscopy.
So patient did well after. Another one, but I think similar lesion, but ulcerated. So this is a 52-year-old female, diabetic and hypertensive, admitted under care of a physician for syncopal attack and hematemesis. There was past history of bariatric surgery. So on admission, tachycardia, hemoglobin of 8.3, patient was managed with IV fluids, infusion of PPI and supportive treatment, and endoscopy was done. So this is an edited video actually. So there was blood initially. This was the kind of lesion after washing. So this is a post-bariatric surgery patient. So what surgery has been done?
I think that's a small bowel which we are seeing down there, and that's the stomach, so it has to be a pouch.
It was a gastric bypass.
Gastric bypass.
So, Dr. Hari, why don't you take this up? Actually, this case was managed by Dr. Hari only. So please tell us.
Presented it was also. The first endoscopy, there was adherent clot. They didn't give consent for any endotherapy. And then the follow-up endoscopy, there were clear visible vessels, they resisted for, because the patient was not bleeding after a single episode. On second, he was admitted 31st or 2nd of the next month, September. After 4 days, he had the bleed. So you can see the next video after that. So next,
I think that video that they managed was not loaded.
That lady was again taken for endoscopy, and there was blood in the esophagus, stomach, and that was cleared off. And later on, the Ovesco was applied, and after that, she went home after 2 or 3 days. So she declared the placement of Ovesco.
We wanted to show that these are marginal ulcers which are not uncommon. They can be as high as in 30% of patients with after bariatric surgery, especially bypass, they can develop marginal ulcers. And you have to do a careful endoscopy to see from where they are bleeding. So I think this will be the last case. 48-year-old male, syncope 10 days back, admitted with pallor. Investigated, 2 PRBC were given, re-admitted with melena and weakness, and on upper GI endoscopy you find something. Dr. Lalit, would you like to comment what it is?
He had history of abdominal pain, you said?
History of syncope.
No history of any surgery in the past?
No history of surgery.
Okay. Because we can't see any ulceration there actually, it just looks like a fistula's opening. Fistula's opening with blood coming. Is it like a politicodiurnal fistula with hemophilia, that possibility? Or?
But I believe on ultrasound there was no evidence of any gallstone or any other biliary abnormality.
And no history of any surgery as well?
No history of surgery.
Pulsatile
Yeah, that's right. You can appreciate that there is something pulsatile is there and blood is using repeatedly. Yeah, something like that. I think I'll request Hari again to detail about it.
This patient was referred to me with this history of 10 days of recurrent hematemesis, and I did the endoscopy first, so that was the finding of fistulous opening and the blood was coming out from that opening. So we did the CT angio after that. On CT angio, there was dissection of celiac artery and isolated dissection of celiac artery extending up to the right hepatic vein. So that was the finding on CT scan, CT angio. And there was collection around that part, and that collection was communicating with the first part of the duodenum, and the blood was bleeding inside, and then the blood was coming into the first part of the duodenum.
So this was very interesting. Patient had celiac dissection at celiac artery origin, which extended into the
that was isolated. That's a very rare. Now I think less than 200 cases have been discovered.
We do not have the films of angio. It was again messed up with this. But it was managed very well, and they did embolize that right hepatic.
So in this patient, the true lumen could not be passed with the guide wire. So what our radiologist did, he embolized the false lumen totally, and the occluding the this common hepatic artery totally. And they went to the celiac, then into the hepatic artery, and they into the false lumen. In the false lumen, they injected the coil and foam, whatever they totally blocked the hepatic artery. And he discussed with me that there may be some risk of hepatic ischemia and kind of that. But after occluding this hepatic artery, he did the SMA angiogram. Some branches were taken off from SMA to the liver. So I think there was no ischemia after.
I've seen that angiogram. What has happened is they had coiled it just proximal to GDA. So after coiling also, the GD was filling up from the SMA side. It was supplying the liver. Ultimately, liver was salvaged because of the GDA. The coiling was just proximal to the GDA. That I seen. We also done one such case where we had put a stent of 80 ml. That stent had eroded the hepatic artery, and the patient was actively bleeding into the stent. So we had to coil the hepatic artery. In such cases, generally, liver can be spared because of collateral. So we have to see where we are coiling basically.
So again, it was nicely managed by interventional radiology. I think the message to audience would be, yeah, Aman, we want to ask.
I think Pankaj has reviewed the images of that patient. I wanted to ask him something.
So what is a dissecting aneurysm or something? What was that?
I had seen the DSA images. What I could see was celiac origin was not normal. And there was some pooling of, like a false lumen, blood was pooling into the false lumen from the celiac origin itself. And what they had done is they had gone into the...
No, but what was the source of bleeding? Dissection usually doesn't cause bleeding unless there is a dissecting aneurysm associated with it.
Rupture as well as a false cavity was found.
And they had
actually... It could be a dissecting aneurysm then.
Yes.
They had glued it. They had put some coils and they glued it. In fact, some glue had gone into the hepatic branches also. That was very documented.
An interesting case. You have seen the image.
So we have already overshot the timing. Apologies for that, for keeping you held here. I think the message in this panel discussion was to the audience would be that GI bleed is to be managed as a team. Endoscopy alone cannot manage. So I just thought I'll discuss that what has changed and what has not changed over the years. We have been practicing endoscopy for 25 years now, more than that. So type of lesion still remains same. Upper peptic ulcer disease still the commonest cause of upper GI bleed. We have better investigative modalities in terms of scopes. We have better CT angio facilities. Newer techniques of hemostasis have come like hemospray, OTSC, interventional radiology has come as a big boom. We have better ICU facilities, better immediate survival. Mortality has not changed much because if you see the literature about mortality in upper GI bleed, they say that the mortality, 98% of mortalities are basically due to comorbidities. Patient usually does not die of bleed, they usually die of their comorbidities. Most of these patients are cardiac patients or diabetics or multi-organ patients. So that is why overall statistics do not say that even in spite of all our efforts, we have not been able to change. So most important management in GI bleed would be assessment of blood loss. That should be the first thing, and managing it. You should carefully look at the comorbidities, any drugs patients are on. You should decide the timing of endoscopy. Do an emergent endoscopy if it is really needed. Otherwise, at night, at odd hours, your performance may not be as good as during the daytime with entire facilities. You should always be ready for a bedside scopy also, because number of these patients are in ICU or on ventilators, and you have to take their scope there. You must plan the sequence of beforehand, that what are you going to do the next. Involve the surgeons and interventional radiologists from the beginning, because that is a very important thing. A lot of such lesions cannot be managed by endoscopists. And family counseling is a must from time to time, because otherwise you will have problems later. And this is, I think, my favorite slide, that in most diseases we must put hand in hand the surgeon, anesthetist, endoscopist and interventional radiologist. Thank you.